everyone. Can you hear me? Great, wonderful. Well, first of all, thanks so much to Dr. Mahant for the kind invitation for me to give you a talk on this topic of OMD and MEIGE. And so Oromandibular Dystonia refers to dystonia of the part of the cranium in the jaw. So it usually involves the mouth, the jaw, or the tongue. So oro means mouth, mandibular means jaw. But there are other terms that are being used to refer to OMD, and your doctors might use these terms, or you might read these terms in your own readings. So the other terms used for OMD include orofacial-mandibular dystonia, orofacial buccal dystonia, so buccal usually refers to the mouth as well, lingual dystonia, so that's the tongue, then jaw dystonia, cranial dystonia, or facial dystonia. So there's many terms that are being used and floated around when we refer to your condition called OMD. But by and large, the most common thing we see as a manifestation of OMD would be opening or closing of the jaw. I'd have to say that jaw opening is more common than jaw closing dystonia. And you can imagine how if the jaw movements are impaired in some shape or form, that chewing would be impaired, would be affected. And this is most true for patients with jaw opening dystonias. It's very obvious if your jaw opens, chewing most likely will be very difficult. Speech can be impaired as well. And in my experience, the speech is most impaired in patients with jaw closing dystonias. I'm gonna mimic, for instance, me biting on my jaw. Your bite on my jaw is so difficult to talk. And in fact, that's exactly how patients with jaw closing dystonia present with. And many of these patients make it to TMJ experts or even speech pathologists trying to figure out what's wrong with their speech, when in fact, the main pathology would be dystonia of the jaw closing muscles. And then over time, some patients, as we heard from Dr. Mahant, some patients with Blepharospasm may develop OMD. And so that begs the question, what percentage of patients with Bleph eventually develop OMD during their lifetime? So it's about 50% or a little bit more, depending on which studies you read. And the most common period where OMD can manifest, or mid-or-facial dystonia after Bleph, would be the first 3 to 5 years. But the truth of the matter is that this can occur anytime during the course of Bleph. So just because you've had Bleph for 4 or 5 years doesn't mean that you have zero chance of the Bleph spreading to contiguous muscles. And if Bleph spreads to contiguous muscles in your face or the jaw, we usually refer to this as MEIGE syndrome. So this is pronounced in different ways. I've heard MEIGE, MEG, MEIGE. I kind of prefer MEIGE. And this was named after a French neurologist who actually wrote a paper describing 10 patients with Blepharospasm. And interestingly, although the disorder now is of Bleph with mid or lower facial dystonia is referred to, as MEIGE syndrome, he only had one patient that had jaw dystonia of those 10, and the rest of the 9 patients actually had pure Bleph. So nowadays, when we see Bleph, and then down the road we see mid or lower facial movements or dystonia or dyskinesias, or if we see frank jaw dystonia, we refer to this as MEIGE syndrome. Now, one other point I'd like to say is that can MEIGE syndrome present with jaw dystonia first? Because so far we've talked about Bleph, given this is the BRF Foundation and Symposium. We talk about Bleph spreading, towards the lower face or mid face. But can MEIGE actually start in the jaw and spread upwards? And the answer is yes, although it's less common for that to happen. I see this most commonly in patients with tardive dyskinesias or tardive dystonia, where they usually have oral buccal dyskinesias first, with or without jaw dystonia. And then with time, some of these patients can develop some spasms of their eyelids as well. And then some of you would have heard the term Bruegel syndrome. It actually was a term that was coined by one of the gods in movement disorders, one of our teachers, one of the founders, I would say, of the field of movement disorders in neurology. It's a very astute, brilliant English neurologist and movement disorder specialist by the name of Dr. David Marston. So in 1976, he wrote a paper on on a patient with Bleph with Oromandibular Dystonia. And just to bring home the point as to what the patient looks like, he had actually alluded to a painting by a French Renaissance painter by the name of Peter Bruegel, the Elder. And this is his painting. It's called The Gaper, and this was painted in 1558. And so since then, after Dr. Marston alluded to this phenomenon or this phenomenology as Bruegel syndrome, we've actually used the term as well. But the truth of the matter is, this painting actually is just an ordinary person yawning. So this patient doesn't have dystonia. So this was a person that was yawning. That was the material for this painting. But at the same time, I think the still pictures brings home the point as to what typical Bruegel syndrome looks like. So eyelid spasms with jaw opening. So this is most commonly referred to as Bruegel syndrome. Okay, so what about spread to below the jaw, which means the neck? So can patients have a spread from the eyelids to the midface, to the lower face, to the jaw, and eventually to the neck? And the answer is yes, although this is less common. And we refer to this as Craniocervical Dystonia. So I'd say I see this, again, more commonly in patients with tardive syndromes or tardive dystonia rather than idiopathic dystonia. And then given that that there's a 50% or more chance of spread, some papers have tried to address the risk factors for spread, and they identified three things. And I think Dr. Mahant also referred to this briefly. One would be previous head or face trauma with loss of consciousness. So it has to be a pretty bad head trauma, a concussion that is, or worse, that may result down the road to development of MEDIAL syndrome. And then females are more prone to spread as well as older age. The average age of onset is in the 40s to 50s, and so it's a little younger than the usual population of patients when we talk about just limb dystonia or cervical dystonia. So patients with MEDIAL tend to be a little bit on the younger side, but if you develop it at an older age, the chances of spread may be a little bit higher. What about spontaneous remission? So the percentage that's been quoted is less than 10%, but the truth of the matter is, at least in my clinical practice over the past 25 years, it's actually rarer than that. And I'd have to say that every patient of mine with MEDIAL that had spontaneous remission had received long-term botulinum toxins. And in fact, some of my patients that get lost to practice, and I kind of try to figure out why they don't see me anymore. Did I follow up on the last Botox injections, or did I overdose? And patient's not happy about the side effects. And then patient comes back a few years later, and then they kind of fill me in as to what happened. And some of these patients say, well, your last shots were so good that I didn't need shots for the next couple of years. So that's spontaneous remission. So it's kind of rare, to be honest. And when patients ask me, so what are the chances of me having a spontaneous remission? I kind of say it's like you winning the lottery. So it's not that common. I say, don't hope for it. But if it happens, then well and good. Okay, so usual age of onset is in mid-50s, begins 40s to 70s. It's very rare for us to see patients younger than this, except those with tardive syndromes. It's very rare to see this in the pediatric age group. It's been described, but extremely rare. Women more than men, the prevalence is 69 cases per 1 million Americans. And usual triggers would be talking, chewing, eating, and stress. So the usual things that stress in particular that worsen movement disorders to start with. And then most labs and scans that your doctor may ask for will be normal. And then Dr. Mahant also alluded to the sensory trick. This is more commonly seen in jaw opening dystonia than jaw closing dystonia. I'm going to show you some videos down the road. And then touching the lips or chin, chewing gum, biting a toothpick, and so on and so forth. Okay, so this is a video that this was a fellow project of mine when I was at Mayo. So I dug up the oldest archive videos from the Mayo Library or archive. And this is one of those patients from the era of post-encephalitic Parkinsonism. It's like the COVID from 100 years ago, from the Spanish flu. So this patient developed MEIGE syndrome with very prominent, periorbital movements, mid-facial. You see him, and lower facial movements. You see him have some improvement of the movements whenever he blows or whistles. So this may be one of the tricks that patients may come up with. Now, in this next video, I'm going to need your help. This is actually a video, not of a patient of mine, but something I just pulled out of the YouTube. And I kind of like this video because it really brings home the point on the importance of sensory tricks. I don't know what the language is, but it's kind of important. I think it's Portuguese, but I need your help. Those of you that kind of know Portuguese, let me know if this is not Portuguese, but I think it is Portuguese. So just listen first.
Quando eu falo que não estou falando mais profissionalmente, muita gente pergunta como? É muito fácil. É que eu tenho um truque que a gente chama de truque sensorial. Isso aqui, ó, que me permite falar. Sem isso aqui, eu não
Amazing, right?
consigo falar. É com isso aqui, eu consigo falar algumas palavras. Porque depois de 10 segundos, o cérebro joga isso aqui fora.
To me, this is either a really
Depois de 10
remarkable
segundos de
sensory
fala,
trick, or is
o
a very
próprio
good
cérebro
actor.
se encarrega de jogar esse truque que eu utilizo para falar fora. E aí volta tudo. Aí, ó, ele já descobriu. Já descobriu o meu truque, e aí conforme eu vou falando, ele vai e joga fora. Esse é o resultado da distonia focal oromandibular.
Now he
Eu
showed you
tenho
another,
1000 quilogramas de peso.
he showed you another trick there. He kind of held his jaw like this. So many of my patients with jaw opening dystonia, they kind of just do this and lean over in the table, put their hand in their jaw, and it looks like just a habit or something, or a normal movement, so to speak. Sometimes we refer to this as parakinesis. These are movements that are used to mask abnormal involuntary movement disorders. So I think it's a piece of plastic or something. It could be anything, and many of my patients actually just chew on gum. Gum is the most common thing. It's kind of awkward if you suddenly spit out a piece of plastic out of your mouth, right, while you're talking. Whereas if you're chewing on gum, it's probably more socially acceptable if somebody sees you chew gum. But it's kind of remarkable. Aside from this, touching tricks around their mouth and their jaw, just putting something in your mouth. And I've seen patients do the toothpick as well, just putting a toothpick in their mouth and just playing around with the toothpick. Makes their jaw dystonia much better. Okay. Now this is an example of craniocervical dystonia. So he's got a jaw opening. His eyes are not very prominently involved. I think I just Botoxed him a few weeks before that. But he still has that, he has his neck dystonia twisting towards the side. And you see that when he kind of puts his fingers or hand in his jaw, the cervical dystonia is pretty well controlled, I should say reduced, for a few seconds, if not more. So again, sensory trick for cervical dystonia, and possibly not, although I'm underimpressed for the jaw as well. Okay, so oromandibular dystonia or MEIGE can include nasal contraction, facial grimacing, lip pursing, sucking, bruxism, tongue dyskinesias, mouth corner retraction, or platysma spasms. And as I mentioned a while ago, this can cause not only difficulty chewing, but slurring of speech. Now, some patients can also develop respiratory automatisms or sounds. I'm going to show you a video down the road of that. So, and this is more common in patients with jaw dystonia. I don't see this in patients with bleph or mid or lower facial dystonia or dyskinesia. It's more with the jaw dystonia, even in the absence of the so-called laryngeal dystonia. So some of these patients with jaw dystonia or oromandibular dystonia present with sounds, involuntary sounds that come out. And then one patient of mine, astutely asked, so what's the difference between jaw clenching dystonia, which is oromandibular dystonia, versus bruxism? Because bruxism is actually very common. It's grinding of the teeth during sleep. So, well, as the term implies, since it's during sleep, so bruxism is only during sleep, right? Whereas oromandibular dystonia occurs when you're awake. And in fact, one of the things that patients with bad dystonia, it doesn't matter what your dystonia is, bad dystonia, one of the things that they look forward to is sleep. Because when the brain just goes to sleep, all these movement disorders, most of them abate or disappear completely when they reach the lighter stages of sleep, and more so when in the deeper stages of sleep. So OMD stops while sleeping, whereas bruxism starts when you sleep. So it's the opposite. Okay, so given that OMD affects the jaw muscles, muscle pain is more common. And in fact, many of my patients with OMD who have a history of migraines say that their OMD triggers their migraines. And then many of these patients sometimes present to headache specialists for the so-called diagnosis of atypical pain, facial pain syndrome, especially those with jaw closing where the dystonia, where the jaw is not, very visibly dystonic or obviously dystonic. And then many of these patients also make it to TMJ experts. So if your jaw is opening or spasming or closing, it kind of wears down the TMJ joints and accelerates the arthritic process. And then as Dr. Mahant mentioned, many of these patients are idiopathic, meaning we don't know the cause at this point. Genetics, about 10% of patients with MEIGE or Bleph have a family history of dystonia. And it doesn't have to be Bleph. It could be some other form of dystonia. And then this is not meant to be a comprehensive list, but there are certain dystonia syndromes that run in families and several members. Like, for instance, I listed the two biggest ones. One is DYT6, and majority of them have craniocervical dystonia. And the other one is DYT3, which is LUBAG, which is seen among men from the Philippines, in particular from one of the islands in the Philippines. So almost everyone, wherever they are in the world, if they have oromandibular dystonia or generalized dystonia for that matter, and are from the Philippines, I kind of have to do this DYT3 or test for LUBAG. So far, we haven't seen this in Caucasians, and we've actually looked at many samples of non-Filipino population. And then secondary causes, and I would have to highlight the drugs, and in particular the so-called neuroleptics. And I'm going to show you in the next slide, I think, an example of tardive dyskinesias presenting as oromandibular dystonia or MEIGE. Okay, and so when we talk about oromandibular dystonia, it's mostly the jaw and the tongue. So let's talk about the jaw first. So what can the jaw do? So number one, it can open. So that's the more common thing I see, the most common thing I see. Number two, it can close. And this is where it gets a little bit dicey, and patients, take a while to be seen by a movement specialist because they're seen by TMJ experts, they're seen by their orthodontist, they're seen by headache specialists, and so on and so forth, because it's not very obvious. Number three, the jaw can protrude forward. Again, not very common. And then even less common of this four, the jaw can deviate towards one side. And I'm going to show you a video later on. Now, what about the tongue? What can the tongue do? So the tongue can protrude. The tongue can protrude. If the tongue protrudes, almost inevitably the jaw has to open. So it's very rare to have pure tongue dystonia. And if it is, I kind of have to make them open their mouth, and I see the tongue kind of, twisted towards one side. And the tongue retraction means if they try to stick out their tongue, the tongue is just stuck there inside. So it's very difficult for them to stick out their tongue. And then the third way that the tongue can be dystonic is that it deviates towards one side. And then medicine-wise, and Dr. Mahant, mentioned some of this. So the most common thing I use would be anticholinergic drugs. And in the U.S., those two most common drugs are benztropine and trihexyphenidyl. Now, the anticholinergic drugs are best tolerated by younger individuals because in elderly individuals, and there's no elderly here, right? We're all young. It causes hallucinations, mental fuzziness, worsening of cognitive issues or dementia, and so on and so forth. Now, what about the benzodiazepines? So this is the clonazepam and the diazepam. So it used to be very easy to prescribe these drugs before Big Brother got involved, and nowadays it's such a pain in the butt, to prescribe benzodiazepines. I know those of you that have tried this, it's also a pain in the butt to get refills, right? Now the refills have to be done every month. You may need a urinalysis every now and then. They'll do a toxicology, and your doctor has to check. At least in Arizona, the so-called Arizona PMP. So every patient on a controlled substance in Arizona is registered there, like it or not. And that board actually looks at all the medicines and prescriptions, controlled substance that you're on, and which doctors have prescribed them. And so because of this Big Brother, thing that's been happening over the past few years, more and more so, we're kind of backed off and are not gung-ho anymore in prescribing benzodiazepines for dystonia. I rarely do this, to be honest. I just possibly refill medicines if they've been on it for the longest time, because it's very habit forming. So once you start benzodiazepines, it's so difficult to wean off, and some of my patients using whopping doses actually have to do drug rehab, to be able to get off their benzodiazepines. And there was a question of muscle relaxants. So baclofen is the most common thing. We usually use baclofen mostly for patients with post-stroke spasticity. It's less impressive, I would say, for dystonia. I think tizanidine has a better effect, at least in my population of patients. I kind of like cyclobenzaprine as well. But all these three have one thing in common. They're going to get you sedated. And your balance will be poor. You may see double. You may get dizzy. And then if you combine the muscle relaxants with other drugs, which is very commonly done, then the side effects are just additive. Okay, what about other drugs with less side effects? What about the seizure drugs? So for instance, gabapentin and topiramate are two of my favorite seizure drugs. They're most effective, I would say, in early or mild bleph. They're not very effective for jaw dystonia, however. But patients with MEIGE, without jaw dystonia, especially in the milder stages, earlier stages, may respond. And then what about the Parkinson's medication? So I kind of think that patients with Parkinson's disease most likely will respond best to Parkinson's-related MEIGE. So we'd see MEIGE syndrome and rarely oromandibular dystonia in patients with Parkinson's disease. And then there is this rare genetic syndrome called dopa-responsive dystonia. So dopa refers to levodopa or dopamine, which is the same drug we use for Parkinson's. So these patients don't have Parkinson's disease. If you do a dopamine scan or DAT scan, the DAT scan is perfectly normal. They present with dystonia. So they don't present with Parkinsonism. So when I say Parkinsonism, so I'm referring to shuffling gait, rigid muscles, tremor, poker face, bent posture, reduced arm swing. Whereas in dopa-responsive dystonia, they have dystonia, period. And the most common place for dopa-responsive dystonia would be a limb, one limb, and the lower limb seems to be more common than the upper limb. Although I've had youngish patients that had truncal DRD. I've had a few that also had some MEIGE presentation for their DRD. Pretty rare, but still possible. And then sometimes I see patients that are overdosed with their levodopa, so to speak, and one of the manifestations of their more advanced Parkinson's would be what we call levodopa-induced dyskinesias. And again, this is in the Parkinson's population. And I use a drug called amantadine. So amantadine helps MEIGE-like symptoms or presentation in patients with levodopa-induced dyskinesias in the Parkinson's population. And then I also sometimes use neuroleptics if I'm desperate. And they're actually pretty effective in treating patients with oromandibular dystonia. The only downside is that these drugs, although they are used off-label for dystonia, and they can be pretty effective, these drugs paradoxically down the road can cause movement disorders. So it's kind of weird. The same drug you use to treat a movement disorder will suppress it, and yet when you stop it, it already has caused a different movement disorder. That's called tardive dyskinesia. So it develops after, I'd say, 6 or more months, although the least, the briefest exposure in literature is about 1 month. And that's usually more common among, again, elderly females. So these are patients usually with a psychiatric history. They're prescribed some antipsychotic drug for whatever. Believe it or not, in the 1950s, the antipsychotic drugs were just being prescribed for psychosis, right? But nowadays, the most common reason for prescriptions for neuroleptics, the so-called antipsychotic drug, is not psychosis. It's not schizophrenia. Believe it or not, it's for other mood disorders like depression, anxiety, bipolar disorder. So these are now the most common reasons for receiving a drug, a dopamine blocker. Also, it's also being used for nausea. So those of you that make it to the ER, you're vomiting, they don't know what the heck is happening, they just want to stop the vomiting, they give you a very powerful dopamine blocker called metoclopramide, which is Reglan. And then if your nausea, persists, they'll probably send you a prescription. Okay, you'll take this once a day, 2 times a day, maybe 3 times a day. Very effective, suppresses your nausea, whatever the nausea is from. But down the road, it causes tardive dyskinesias like this. Okay, so you see the bleph, and then you see the mid-facial dystonia, and then you see the jaw opening dystonia. And what else do you see? You get extra food, extra points. The neck, right? The neck goes downwards. So this is not just tardive Meige. If you want to be really very accurate in your description, this is actually tardive craniocervical dystonia. And the best way to treat this would be the so-called VMAT2 inhibitors, which we use for tardive dyskinesias, and there are 3 in the market. Now, jaw dystonia is very prominent in DYT3. So this is a patient with DYT3 or XDP or LUBAG. It's really tough to treat. First of all, there's only a finite amount of Botox I can give, right? So if you have dystonia of your eyes and your mid-face, your lower face, your jaw, your neck, your trunk, I can Botox practically everything. First of all, nobody's going to pay for that. And secondly, it's probably not safe to give you super whopping doses of botulinum toxin. Remember, it is a toxin. In fact, it is the most powerful toxin in planet Earth. And therefore, we kind of have to use really minuscule amounts of this for it to be effective. So I remember when, this is not the first case, but there was a first case that I tried. I was so desperate because jaw dystonia was a feature that was so difficult to treat in this population of patients. I remember one patient of mine with LUBAG one day says, after I've been trying everything, throwing everything at him short of the kitchen sink, and finally, the patient just says, "Hey, doc, you know what? My movements stop when I'm asleep. So why don't you just give me a sleeping pill?" Right? So it's kind of blow to my ego when he said, "Just put me to sleep." When he said, "Put me to sleep," I thought, well, am I going to kill this guy, or what does he want? Okay. So what he wanted was a sleeping pill, so that he can just take the sleeping pill when the jaw gets very painful, spastic the entire day, or the other muscles like the neck. So one day he comes back and he says, "Well, you know what, doc? That medicine you prescribed called ZOLPIDEM, which is Ambien. Anyone knows Ambien? Yeah, it's a very common sleeping pill, right? Very common." So I gave him Ambien. It was the newest kid in the block among the sleeping pills during that time. So I prescribed him Ambien, and he comes back one day saying, "You know what? That Ambien didn't put me to sleep. Useless. I couldn't sleep. But it treated my dystonia." And I said, "No, it's not a dystonia drugs." And so what I did was, similar to that first patient, this particular chap, I gave him ZOLPIDEM in my office because I was a doubting Thomas. And this is 1 hour after taking ZOLPIDEM. It's miraculous. And in fact, for jaw opening dystonia, and you can read, there's even videos of this in the internet. I remember not long after I published a paper on ZOLPIDEM and its effect on dystonia, there was a radio announcer with Oromandibular Dystonia. Can you imagine a radio announcer with OMD? It's probably, a career-ending, symptom or disease, right? And he says that, he swore by the Bible. He says, "The most effective drug I've tried so far is a sleeping pill called ZOLPIDEM." So if you're desperate and if your doctor is willing to try this out, it's actually pretty effective. This is the sounds I was referring to. We hear this. This is observed in patients with jaw dystonia. Not everyone, but some of them. So he kind of goes, it's almost like an inspiratory, gasp that he presents with. But you saw the eyes move in, facial movements, the jaw, and now the neck. So this is craniocervical dystonia. And then, although this guy had DYT3 Lubac dystonia, I tried one of the VMAT2 inhibitors back then, which was, and the only one back then was TETRABENAZINE. And this is after an hour after TETRABENAZINE. I tested this in my office as well. Again, remarkable improvement. Again, off-label use, the so-called VMAT2 inhibitors are used for tardive dyskinesias, meaning if you have a history of having taken neuroleptics, and then you develop this abnormal movements. And mind you, it usually starts around the mouth. The classic presentation of tardive dyskinesias would be oral buccal dyskinesias. So their mouth is kind of squirming like this, and then their tongue can dart in and out. But a good percentage of these patients may also develop some blepharospasm as well as jaw opening dystonia, as I showed you in a previous video. Okay, so what if the drugs don't work? And whereas in blepharospasm, I would probably just say, you know what? Let's not beat around the bush. Life is too short. Let's give you quality of life. I'm not going to try, a gazillion drugs on you. Let's go straight to Botox or botulinum toxin that gets pre-authorization and everybody's happy. Not so with oromandibular dystonia. So with OMD, I kind of want to try the drugs first. Now, Dr. Samantha mentioned the 4 toxins in the market. So there's Botox, there's Xeomine. These are FDA approved for bleph. And then for cervical dystonia, in case you have craniocervical dystonia, the ones that are FDA approved are 4 toxins, and 3 of which are type A, and 1 of which is type B. Now, I had the good fortune of participating in the development, in research and development of the latest toxin in the market, which so far is approved only for wrinkles. It's called Daxxify, or that's the name of the toxin. It's called Daxxify. It is FDA approved for wrinkles since September. And of course, I wasn't involved in the wrinkle research. I was more involved in the dystonia research. And so the studies they've done so far on Daxxify, which is daxibotulinum toxin A, that's the generic name for Daxxify. They've studied it for cervical dystonia and upper limb spasticity so far. I'm not aware of it having been studied for blepharospasm. But having said that, can we use toxins off-label? Absolutely. And usually Medicare is very forgiving when it comes to using any of these toxins, especially so if you've demonstrated that the patient is not responsive to another toxin that was FDA approved for that indication. Okay, so if we are going to use the toxins, then we need to know the anatomy. So we really first have to diagnose you with dystonia and then kind of analyze, okay, what's happening here? Because if a patient is injected in the wrong muscle, you can make the dystonia worse. And that's especially true for the jaw. So jaw opening is easy. I mean, it's so obvious, right? The jaw opens. So we inject these 2 muscles, and then if it's jaw closing, we inject a different set of muscles, and then if your jaw protrudes, we inject the medial lateral pterygoids, and the jaw deviates towards one side or the other. Then we kind of choose between the medial lateral pterygoids. So you really need a good clinician to analyze exactly what's happening and to make sure that they really inject the right muscles. Botox, botulinum toxin, is a wonderful drug, but only if you inject it to the right places. Because if you inject it to the wrong places and or wrong sites, you'll get no benefit, and worse, sometimes you even get worsening. Okay, so for instance, for jaw closing, can you guys bite? And can you feel this muscle here? Bite. Right around here, in the angle of your jaw. You feel that muscle? That's the masseters. So that's the most powerful jaw closing muscle. Okay, next I need you to put your hands right here where your temples are. Okay, bite. Did you feel a muscle there? If you're too forward, you won't feel it. You go a little backward near the hairline, you'll feel it. Okay, bite. Okay, that's the temporalis. So for jaw closing dystonia, I hit the masseters most commonly, but boy, I'd say about 50% of my patients with bad jaw closing dystonia will benefit from additional shots of the temporalis. It just brings it across the finish line quicker if you do both temporalis and the masseters. And then some patients of mine, and these are zebras, I call them zebras. So they have jaw closing dystonia, right? And then I look for hypertrophy of the masseters, and it's not hypertrophy. Hypertrophy means they're very big and bulky. They're not hypertrophy. There's also no hypertrophy of the temporalis. I inject those two muscles, and they come back to me saying the shots are useless. Nothing happened. So what's the third muscle I address? It's called the medial pterygoid. So this one, you're not able to palpate because imagine the masseters outside here, which you can palpate. Well, imagine the same set of muscles, but inside your jaw. So that's exactly what the medial pterygoids are. So I usually hit this when patients with jaw closing dystonia do not respond to the traditional muscles that I inject. Now, what about for jaw opening? To me, the most effective muscle to inject for jaw opening dystonia is the lateral pterygoids. But again, this is a very deep muscle. I'm going to show you a video in two or three slides later. And then for jaw opening, I also do the so-called digastric. So this is so easy. Just tip your head backwards like this. This is the tip of your mandible, and there's this muscle that inserts right here and goes sideways. That's called the anterior digastric. So it's very easy to approach. And in fact, I remember Dr. Jankovic one day quizzed me and asked me whether I use EMG for targeting the digastric, and I said, well, yeah, I do. That's how, my teachers at Mayo taught me. And he said, no, I just palpate it. He palpates it and sees, feels for the digastric. He makes them open their jaw, and then he's such a sharpshooter. Okay, this is an example of jaw deviation dystonia. So what direction is her jaw going as she talks? The clue is in the mouth, corner of the mouth. So what direction is the jaw going? To the right, absolutely. Okay, so when I see this, okay, I kind of say, okay, I have to inject the ipsilateral, mean the same side, the right medial pterygoid, or I have to inject the left lateral pterygoid. So it's really crucial that your doctor really sits in front of you and really analyzes you. And most of the time, I even videotape patients so that if there's any doubt as to whether I injected the wrong muscles or not, I gotta review the pre-injection video and say, okay, where did I go wrong there? Did I analyze this wrong, or
bite?
What it is?
Keep biting, bite, keep biting, bite, bite.
It's a master.
Just relax. Okay.
Again, some doctors don't like to use the EMG. I am an EMGer. I kind of love that machine. And the only reason I like it is because if you go too deep on the masseters, or too anterior, meaning towards the corner of the mouth, you might hit the buccinator. So the buccinator muscle is that muscle that makes you puff your cheeks like this. So you're able to puff your cheeks as the buccinator. So if you influence the buccinator with your toxin, but either because you were too anterior or too close to the corner of the mouth, or if you use too high a dose into the masseters, and it kind of diffuses towards contiguous muscles, what's going to happen is you will end up biting the inner cheek. So some patients, and some of you might have experienced this, those of you that get shots for their MEIGE, some of you may end up biting your inner cheek. And the reason for that is because the buccinator was jaw opening dystonia. Again, under EMG. So once I know I'm there in the muscle, I inject. Now, what if you're too deep? Then you'll be in the tongue, and you don't want to inject the tongue. Trust me. Okay. Now this is the lateral pterygoid for somebody with jaw opening dystonia.
Open.
This is
Close.
the most difficult,
Open.
in my experience,
Keep it open.
type of injection that a movement specialist can do. Also one of the most dangerous.
Push against my fingers, okay?
this is so difficult because, first of all, the lateral pterygoids are pretty deep. So I kind of use a 3-inch needle. I don't show the patient the length of the needle. Don't want to scare them away. But, you know, I kind of do it. I kind of say, okay, look away. And then I kind of bring out my 3-inch needle, which is, you know, a little shorter than what you do for lumbar punctures, to be honest. They're pretty nasty. And they're pretty fat, too. And so, and there's no anesthesia for this because you just, you know, go in. And then you just... This is one of those kind of injections where, you know, I kind of say a Hail Mary first before I, you know, stick the needle because, number one, if the patient closes his or her jaw by reflex, the needle gets bent and gets left inside. That's why it's happened. Yeah, I remember there was one case at Mayo, not by me. I just heard about it. Where the needle had to be extracted by a surgeon because by reflex, the patient just closed his jaw and the needle got fractured and just got left inside. Okay, this is for the medial pterygoids, for jaw closing dystonia. Where the masseters are not hyperactive.
You're okay?
It's the inside of the jaw. Put it right here.
Bite. Bite. Relax. Bite. Relax. Bite.
See that?
Relax.
It really
Bite.
confirms it, which is why I
Bite.
love the EMG. I would even have to say, I think it will be risky, if not stupid, for someone to do the shots like this without the EMG machine. Just say, okay, I know where the landmarks are. I can find this muscle. No, you can't. Because it's not as easy as you think. Okay, what about the tongue? So this is the top of the tongue. This is your chin over here. This is the bottom of your chin. So we inject the genioglossus. That's the meat of your tongue. And we usually do that for patients with tongue protrusion dystonia. Rarely, and I don't do this because it's so difficult, technically difficult. The styloglossus for patients, which is this muscle right there. And the only way to approach that is from above, because you really need a long needle from the bottom, from here, to be able to reach that to there. But anytime you inject, from the mouth, it's kind of very risky because the mouth is full of bacteria, and so the chances of post-injection infections would be higher if you approach the tongue from inside the mouth versus from up here, or from down here, I should say. Okay. So this is the most impressive tongue dystonia patient I've ever had. Started with Bleph first. So the tongue is so hypertrophied, and you kind of notice it's going out and kind of going towards one side. So this is not tardive. This is a patient with DYT3 dystonia. Started with Bleph, and then mid-facial dyskinesias, and then progressed to tongue dystonia. Here's the opposite. And I'm telling the patient, stick out your tongue, stick out their tongue. And he couldn't stick out his tongue. That's as far as his tongue would go. So this is a tongue retraction. So it's a different muscle. So it's really important. Your doctor will kind of say, okay, what exactly is happening here? Which muscles are dystonia? But this is an example of genioglossus.
Stick it out. Move your tongue inside. Stop.
Okay, so the problem with this is if you're too superficial, you're in the digastrics. You're too deep, then you may actually go out into the mouth. So it just has to be perfect. And that's where the EMG comes in. So tongue dystonia injections, a little bit dangerous. I'm not very thrilled whenever I have to do one because excessive weakness of the genioglossus can cause obstruction to the pharynx. So the tongue literally goes back, especially during sleep. They can actually choke on their own tongue during sleep. But again, I do tiny doses and I use EMG and I kind of say, we're gonna aim for 10% first for this set of injections. And then Dr. Subramanian this afternoon will talk to you about physiotherapy and all that, alternative interventions for oromandibular or Meige syndrome. And then there's different kinds of dental devices or oral appliances. Usually it's the orthodontist that will talk to you about this. And then Dr. Mahant already mentioned, a few surgeries, which I would have to say, I have some patients, though, that have had blepharoplasty that disappeared from my practice for a few years because they had a remission. So blepharospasm, I've had a few patients, a handful at least, that tell me, well, I didn't need your shots because I underwent, blepharoplasty and eyelid lift with my ophthalmologist. I've also had a few patients where when they come back, and now I have to do the shots again, and I kind of compare, okay, what was the dose now versus the dose before the blepharoplasty? And there was a little bit of a decline. There's not as much, toxin that was required to weaken the muscles, I'd have to say. And then if you failed everything, the deep brain stimulation, I'm going to end with this. I'll just show you some examples. I'm not going to elaborate on this. We're going to have a full talk on this after lunch with Dr. Ponce. So here's somebody with jaw and tongue dystonia. This is oromandibular dystonia before DBS. See the tongue going out, sticking out, the jaw opening. And this is him 3 weeks after DBS. And this patient, we went through everything, medicines, different kinds of botulinum toxins, and so on and so forth. Okay, here's somebody with MEIGE. So with a lot of, mid-facial, maybe a little bit of perioral, but and then if you do the side view, you kind of see her neck kind of going backwards there. So maybe this is not just MEIGE, but this is craniocervical dystonia. Again, patient went through all the toxins, medications, became resistant with time, and this is her 3 weeks after DBS. It's remarkable. We actually published this because it was remarkable. And then I think this is, hear that? The respiratory sounds. So eyelids, jaw opening, and the sounds. And again, this patient didn't respond to medicines or had an insufficient response to toxins. 2 weeks after DBS. Remarkable. Really is. It's not for everyone, though, I'd have to say. Some patients don't respond. I really don't know what the factors are. I don't have enough patients yet. Maybe we can ask Dr. Ponce as to what predicts a good response versus not. Now, can you have DBS with pure bleph? In other words, you don't have MEIGE. You just have bleph, period, and you stop responding to anything and everything. The answer is yes. And there's very, very few cases of this in literature. And this is one case we published, I think, last year. I think he was like the 4th or the 5th case in the world. So this was him before DBS, and this is him after DBS. It's remarkable. Yeah. The target for this was the globus pallidus. I think the GPI, and we'll ask Dr. Ponce this afternoon, the GPI might be a better target for pure bleph. There's also some reports of the thalamus, but I think I've had one or a couple of patients that would have a good response with thalamic DBS, mainly those with hand tremors, and they kind of say, why don't we try to hit 2 birds with 1 stone, your hand tremors and your eyes. Well, the hand tremors improved and the eyes did not with the thalamus in those patients. And with that, I'm going to end, and I'll be happy to take a few questions.